So good afternoon and welcome back to our second session of the day. Now tomorrow at this time we'll be conducting an exam, right? So that 1 hour, tomorrow's, that is 3B, right? That would be a sort of exam. Now what I'm planning is that let's cover everything in this exam, right? Everything we'll be learning, we learned yesterday, we learned today, and in tomorrow's first session. That will take as a part of the exam. And because it's like an honest exam, so in case even if say you miss to answer any of the question, no need to worry, right? Because we'll be answering all of them. Well, few of the questions which were asked, yes, it is the sympathetic system, right, which is inhibited during the pregnancy, because it is like say it is the uterus which is protected by from contracting, right, as we really want to relax the uterus so that baby is not spilled out. So actually not inhibiting, it functions it that way. So that's why I said that in parasympathetic it varies, right? It goes from stage to stage. Anyway, more things will come, and in this session we'll be covering, yes, I'll be handling the sessions. How will be the exam? Well, exam would be like on the screen, right? You will watch, let's say, number one, and there would be a question, and there would be, say, 1, 2, 3, 4 options. So on your page you just write one, and then if you feel that correct answer is B, so just write B, right? And after about, say, 30 seconds we'll change the question, right? That way we'll go for the first round of at least, I feel, about, say, 25 questions, because that will give us a good coverage, right? 25 questions we'll keep, and then we'll go back to those questions and then we'll start answering them, right? So that would be the pattern. So let's start with our current session's topic. Sorry for the disturbance, but well, okay, is it the same PDF, right? Is it this what we are supposed to study? This is like AWG. So you might be wondering that, are we into some engineering class? Yes, this AWG is American wire gauge, right? Because whenever you go to buy any of the wires, right, these are all the electric wires. So it is said that, okay, tell us what wire you want, right? You want 22 gauge wire, or you want 18 gauge wire, or you want even, say, like this, a 36 gauge wire, right? So what are we talking about? Well, this gauge, just for the knowledge, when it is written that gauge, it is 1 upon nth number, nth part of an inch, right? So when we say that, yes, we want to, say, install air conditioner, right? So then we'll be requiring 18 gauge of wire, right? Our normal gauge of wire won't work. So this 18 gauge wire is the thickest, or the 22 gauge wire is the thickest? Well, because it is the 22nd part of the inch. So obviously 1 upon 22 is surely smaller number as compared to 1 upon 18. So as this number decreases, the gauge or the thickness of the wire, it keeps on increasing. Why do we really want to do this thing? And in fact, it's a medical class, right? We are not into some electrical class. But well, if it's the same principle which will be applied over there. See, these wires, right? These wires, they are thick as we really want to pass heavy voltage through it. Heavy voltage. right? That load would be more. So same way, even when we say that 220 volts, right, that is the current, but on those transformers the voltage is way high, right? Take exam on a Mentimeter app. Okay, okay, I'll just write it down. Okay, in fact, honestly, I have not checked it, but I'll surely write it down over here. It is what? Mentimeter. Okay, I'll check it out and will update you. Otherwise, at least we'll be discussing those questions over here, but I'll just see this app, how good it looks and how well we can really plan on it. Is it a paid app or it's a free app? Okay, so these are the wires, and then there are thin wires whose gauge is like say 36. So that means it is like 1 upon 36, 36th part of an inch, right? So that's pretty thin. Okay, all right, okay. When it comes to nerve fibers, things are not much different. They are quite similar, right? In case of nerve fibers, say there are few types. And how do we really learn these types? Exactly the same way, the way we learned those wires, right? Same style. But here, someone got a Nobel Prize for doing this, right? A Langer-Gasser classification, that is what is called as. It is considered as a very classical and very authentic classification. But it is based on this simple principle that these myelin, right, they are directly proportional to speed. Obviously, right? Obviously, because it is because of myelin, because of those nodes of Ranvier, those potentials, they are jumping and they are increasing its conduction speed. So that is true. And the thickness, right? Same principle as that of those wires. So let's see it this way. And this is the easiest method, that we do have A, B, and C type of our nerve fibers, right? Now in A, we have got alpha, beta, gamma, and delta, right? That's delta, and that's gamma, beta, and alpha. And then in B and C, there is nothing like that, right? They are simple as it is. Then we differentiate it from one, how much is the quantity of myelin? If the myelin is more, right, it is like right from the beginning, from alpha, it is the maximum. And in type C2, it is nil. There is no myelin. So they are demyelinated. That means they will be appearing gray and these will be appearing white. So its color will be changing from white and will be going towards gray. All right. This is the conduction speed, right? No big rocket science, because more number of myelin, more amount of myelin, better the speed. From 120 meters per second all the way it drops down to 2 meters per second. Right? That's how it goes. It is simply because of the myelin. And thickness, yeah, exactly. Maximum thickness. Zoom out. It's already, I think it is full screen. Because if I'll zoom, say it will cut the picture, right? We won't be able to see that thing properly. So this is, it drops to 2, and the thickness, right? That's the thickness. So this is because of myelin. Maximum thickness to it goes down to the minimum thickness, right? So that's what is called as the Erlanger-Gasser classification. Now, where exactly we use this piece of information? How do we use it? Here is our group A, right? A group A in which there was alpha, beta, gamma, and delta. So alpha, right? That alpha is present in motor, that is in spinal cord, and sensory proprioceptive situations. So yes, these are the areas where we require immediate attention, right? Motor and the sensory. The way it was said that why those dinosaurs they got killed, they became extinct, because actually their conduction speed was very low. So if someone is eating their tail, right, they used to know it after few minutes. Right? That was the problem. So that's the reason that they were unable to react so fast. Though it was like their bodies were huge, but relatively their brain size was very small. So over here, our maximum speed is on motor and neuron, right? Proprioceptive, that is position in space. And now position in space, that means which lobe are we talking about? Which lobe of our brain we are talking about, right? That would be one of the question for tomorrow, right? So I have leaked that question, okay? So position in space, right? Which lobe, that would be the question for tomorrow. That's true. Okay, parietal lobe. Moving on to this type B. Type B is for touch, right? This is absolute sensory. Now see over here, this is mixed, correct? This is mixed, while this is absolute sensory. Do remember this, because there is one more classification which is coming up, and we do need to remember these classifications, because some of their use, they are specific for certain conditions and certain diseases, right? So over here, just keep on remembering as we are discussing that which are absolutely sensory, because there would be next classification which will be based only on sensory. It will not take into action the motor one, right? So this beta, that is A beta, right? Group A beta, they are absolute sensory and they are for touch, okay? Here is gamma. It is just the reverse of it, absolute motor. So we have mix, we have sensory, we have motor, and this is bit unique. This is bit unique. This delta is for first pain sensation, right? This is for first pain sensation. That is the delta. When it comes to beta, right, or the B, right? This B is preganglionic fibers. So now we see that yes, this B is preganglionic fibers, right? As they are coming from the spine, and then there is our ganglia, and from here things are going out. So this is group B. Now when I go back to our classification and we see where is this B. Okay, so this B is having, well, it is not very fast. It is relatively quite slow, right? It is slow. And its thickness is also not very high. Yeah, it cannot be, because it's a narrow space. And it has not got much of the myelin also. Myelin is also less, because the distance is small, right? It's a small segment, so that's why it's okay to have less myelin. And it is so slow. Well, someone asked very interesting question, that when the body is in formation, right, why it never happened that everywhere the myelin was put, because we don't have to pay anything for that extra myelin supply from the God, right? So God should have kept myelin on all of our nerves, so that all the nerves, they would have gone at a very high pace. That God is not going to send us the bill that because you used say 3 kilograms of myelin and per kilogram this is the rate, so send it. right? It wouldn't happen. But well, that's how the embryology goes, right? And that's the reason that embryology is so interesting. Say, yesterday when I was talking about, say, foregut, midgut, and hindgut, the moment you learn the histology of it, everything becomes so interesting that then you realize, okay, this is how all these rotations occur. This is the reason why these nerve supplies and blood supplies, they are like that, right? It's an amazing process, so systematically arranged, and everything is forming the thing what is called as the differentiation. This is what always fascinates me. It is like differentiation. What differentiation is, that there is all that particular cell, right, that pluripotent cell, that cell himself is not knowing that what I'll become, and then there comes all the signals, and then that cell starts developing, and finally there is formation of blood, there is formation of bone, and there is formation of, say, soft tissues. But basically everything came from just one cell. That one cell divided to 2 to 4 to, and then blastula, and then all those stages. But so interesting, right? How this ectoderm, mesoderm, and endoderm develop, how they penetrate into each other, and then they rotate, how those discs are, they are formed, how the notochord is formed, and then the heart and everything, right? Such an interesting process. So it's actually like a story, right? It's just like a story non-stop. It keeps on happening. Okay, so this is first pain sensation, that's delta. So if there is like first pain sensation, so there has to be second pain sensation, and here it is C, this, that's second pain sensation. It is the slow conduction, and that's postganglionic fibers, right? Yes, yes. So nerve fibers group A, B, and C all are found in same position, like B are preganglionic, whether it is sympathetic or parasympathetic. That's right. That's right. Right. Because their association with that, what exactly will they do, that is coming next. But that's right. These are simply as per their position. That's right. Simply as per their position. So when we say postganglionic fibers, they are for second pain sensation. They are slow conduction. Now you can actually get a feel of it, right? Say why it has to be like the first pain sensation is so fast and the second pain sensation is slow, right? This first pain sensation is for the defense, that if anything is giving pain, let's say, if you really want to feel it, but well, there is a small amount of risk, but let's say the tawa on which we make that roti, right? When it is very hot, right? Obviously, don't put your hand like this and close your eyes and try to feel, right? It is like you touch and then take the finger away. And then you will feel that, yes, after some time, you are getting that feel, right? Slowly, no, test is tomorrow. And slowly you'll start getting the feel, and then you feel, it is hot, right? It is giving pain. So that's one of the experiment, right? Do it at your own risk. I'm not telling you to do it. So this is the second pain sensation, slow conduction and postganglionic fibers. Okay. Now this is what's called as the Lloyd's classification. Lloyd's classification, it's only for the sensory. Sorry. Yeah. It is only for sensory. So let's start with that. For a alpha, right, there was sensory component. Right. A beta, there was sensory component. Then for a gamma, it was purely motor. So that is not part of this. Okay. Then a delta, that was first pain sensation. So that was sensory. Right. Then what was next? B. B was what? B was, if you see, it was what? It was preganglionic, right? So again, not pure sensory. And finally, this C, which is having slow second pain. So that is the class 4. So here they have got 1 class A, 1 class 2, class 3 and class 4. When such things come, they become very interesting questions for the exam. Because when it is said that mix and match, and it is said that, okay, as per this Lloyd's classification, class 2 fibers, right, they are associated with what type, right? And then all the options which are given. So that's where you have to come up with A, beta. Right? As such, it is simple. If you just remember alpha, beta, gamma, and delta, so this one is mixed, this one is sensory, this one is motor, this one is for pain 1. Then class B, which is for those postganglionic, and class C, it is for that second pain, right? So we are dealing with this, we are dealing with this, we are dealing with this, and this is 1, 2, 3, and 4. So that's the Lloyd's classification. This is for proprioceptive, we have talked about, right? You rightly said that's for parietal lobe, and I'll just add the 3D so that your orientation in 3D. Okay. This is nerve fiber injury. What really happens when the nerve fiber is injured, right? Common in fracture, yes, because we said that one of the very commonest fracture, when the bones they break, and many of the nerves, they are closely associated with the neck, right, or with the shaft. So when the bones break, they also destroy these nerves. When the nerves are destroyed or the injured, it will lead to so many neurological complications. So it is common in fracture, common in stabbing, right? When the stab is there, you don't know, right, where the knife was moving and your patient got injured. And accidents, they are always accidents. So very common in this fracture, stabbing and accident. Following nerve injury, when it comes to say CNS, it is the most unfortunate. Neurons degenerate. They degenerate. Only in the peripheral nervous system they do degenerate, but then this is a small happy part, they regenerate. Otherwise, in CNS, there is no scope, right? Once gone, it's gone. Anything happens to heart, it's forever, right? There is no scope. So here it is, our standard cell body, right? And then there is axon, and then these were the dendrites, and then these were the terminal branches, and injury, that's the injury site. So obviously this thing will be called as the proximal part, and that's the distal part. So this distal degenerates within a day, right? So instead of writing within 24 hours, I just got the idea that I should write within a day, right? That makes things more musical, right? So this is like, it is the distal portion which degenerates within a day, right? What really happens? This is called as the Wassermann degeneration. Some names must be remembered, and as you will study, they will come automatically. The first thing first, this is 1, this is 2, this is 3. These are the 3 things. Okay. These are the 3 things which can really happen. One is, first, axon, it starts getting degenerated. There is myelin degeneration, and then finally phagocytes will come and they'll clean up everything so that all the dead tissues, they are eaten up, and it's like a cleansing process, right? So after about 36 hours, after 1.5 day, it is the proximal degeneration starts. So initial attack, right, it is the distal part, it is degenerated, and after 1.5 day, it is the proximal part which starts getting the toll. So in the proximal degeneration, Now you know this, right? I need not even explain because you know this. Nucleus becomes eccentric. It is pushed away from the center. Yes, right? We have already learned that. So that is easy. Nasal bodies. So in cell body, right? In cell body, there are several structures. One of the structure is endoplasmic reticulum. There are two types, rough and smooth. So these nasal bodies, they are into this rough endoplasmic reticulum. So when they disintegrate, right, so many other structures are there. But some of the names one must remember, as those names they can easily be asked into any of the exams. And then it becomes like a pain if we miss such questions. Right? Sometimes you will feel that why such names are to be remembered. Friends, if you will not remember, someone else is remembering it, and there would be few questions where you have to apply your logic and then you have to come up with a conclusion. Even others, right? Whenever there is war, there is a one very good book called Art of War, right? I'm not telling you that you go and fight with everyone, but this Art of War is one of the very fine book for the strategy. As such, it's like a war. You know? It's like a war. Say you will be competing stiffly with everyone, right? So it's like if we don't learn one topic, or we say that come on, forget about this chromatoclysis, why to remember such word? Fine, but what if this question comes and someone who has really not read very properly, he answers this, he clicks correct and you click it incorrect, and then the next question is where there is something which is quite complicated and you come up with the correct answer, that person makes a mistake, both are at the same level because marks they are same. So in the exam pattern, it is always like some of the questions, they are like basic concepts, right? This is the area where you should be dead right, right? No confusion. There would be some questions where it is necessary for you to learn properly because there will be few trick questions. Though we'll be discussing all these things in great length tomorrow night at 10 o'clock. Right? Yesterday I couldn't get the time to make that link, but today you will definitely be getting that link. It will appear. Right? That is tomorrow at 10 p.m. night, 2200 hours. Okay. But then there would be some tricky questions where you are really putting your heart and soul. These questions, the exam pattern, the new exam pattern is such that no test would be as such, so it will be done over here only, right? Like that's what I said. It would be like an honest test, right? I'll keep on showing you all the questions, right? You have to answer. You have to write down in your own book. Tomorrow, same time. That is our second session. That is 3C, right? Session 3C at 12 o'clock. Okay, coming back to this, say this chromatoclysis, that is such word, right, which you just tick, granted correct, and then you proceed. Okay, so this art of war, yes, that's a strategy. Tomorrow in the evening hour, that is at 2200 hours, when we'll be discussing this, yes, we'll surely be talking about it, right? All of you are like commandos. You are like soldiers. You have to really make yourself physically and mentally fit so that you are absolutely great on this, say, over 5 years of marathon, right? It's not a sprint, it's a marathon. So that's why your physical fitness, your mental fitness will play a major role. So it's not only that I'll be giving you a timetable that, okay, you finish the anatomy in 6 months and then you finish this physiology. That's okay, that would be there. But at the same time, we'll be going to that granular level. That is, every morning, can you spend just 20 minutes for yourself? And every night, can you spend just 10 minutes for yourself? Because it would be a combination of, say, physical fitness and mental fitness. That is, I'll also give you, I'm planning to give you some music also, right? Which can be very helpful for your good sleep. By the way, just quickly, so regarding this PDF, I'm planning how to, because some of the images and everything, don't worry, I'll manage it. What I am telling you is, what I was asking, sorry, it slipped from my mind. I was about to ask you something. Oh, I'm sorry. Okay, well, let's continue. That thought will come, right? It just evaporated. I just missed it. What I was about to ask you. Okay. Anyway, so nasal bodies, they are into rough endoplasmic reticulum. They disintegrate, and this thing is known as chromatolysis, right? Do remember this, right? I'll ask in exam, right? Chromatolysis. And this eccentric, right? When the nucleus is pushed on one side, because these are the specialities. All right. Regeneration of, yeah, what I was asking was, see, this is how it happens. How many of you, as such, I'm planning to put it onto the poll also. Do answer in that also. But how many of you sleep after 12 o'clock? After 12 o'clock. Or you can say it other way, that how many of you sleep before 12 o'clock? Right? By the time, and when I say sleep, that means you are actually into deep, good sleep, right? Before 12 o'clock. Because even if you go to bed at 11 o'clock, but if you are tossing and you get your actual sleep at 1 o'clock, so then it is not justified. Okay. Okay. Good. You don't sleep at night. All right. Okay. After 12, before 12. All right. After 12. Okay. Okay. All right. I think if you go to sleep before 12 o'clock and then actually you are getting a good sleep. Oh, if there is acute insomnia and you are getting sleep for just 3 hours, dear friend, you are really hurting yourself very badly. And all those friends after 12, after 12, after 12, so many after 12. Oh, okay. Okay. 10 to 4 is what's my timing also, right? I also go to sleep by 10:30, right? And invariably wake up at 4 o'clock. Okay. Okay. Fair enough, right? We'll talk about it. Because if you are sleeping for so less hours, just 3 hours, that is painful. See, you are at this point of time, so you are in the best state of your body. Your energy levels, they are the highest, right? In your 20s. So it is so good. That's why even if you sleep less, even if you insult your body is powerful enough to take that brunt. But its effect would be seen at a later stage. Right? So definitely tomorrow at 2200 hours, we'll talk about it. And we'll make sure that we finish it by 11 o'clock so that you can go back to your sleep properly. Okay? Or can we start it a bit early? Instead of say 10 o'clock, can we start it bit early? Yes, sure, we'll talk about it because suddenly it came in my mind as we are discussing this topic. So indirectly, we'll be talking about the physiology of sleep also, right? So I would need a cushion of about say half an hour. And if I'm supposed to finish at 11 o'clock, so can we start it bit early? No. Uh, can, okay, Soumya, she said no. Yes. Oh, really? Let's do it this way. We plan it at 9:30, right? 9:30 p.m. In any case, the recording will always be remaining there. So say in case if someone has lost any portion, right, they can always have a look at it. Okay, okay, no problem. All right, so come on. So let's go back to this regeneration of nerve fibers. In CNS, so there is no scope. In case of PNS, peripheral nervous system, yes, it starts. It starts slow, very slow, 1 to 3 millimeter a day, right? That's the speed at which it starts regenerating, right? And it starts after 90 days of injury. It's not immediate. It starts after 90 days of injury, and it's a slow process, 1 to 3 millimeter a day, and it starts regenerating. This happens only in nerve fibers, right? To test, that's what is called as the Tenons test. That's what is called as the Tenons test. Do remember this name, Tenons test. Tenal, whenever you say tenal, is it similar to tingling? Right? It is similar to tingling. So that's what it is. That when, if the nerve is injured, you tap on it, and if there is any tingling sensation, that means it is good. That means that it is a positive sign of regeneration, right? Tap over injured nerve, and if there is any tingling, that means it is the tenal sign is positive. These are some of the facts, and these facts, they are the favorite questions, right? In which is the nerve which recovers best, right? Now, though this thing will come in orthopedics, right? That when the radial nerve, that prognosis of radial nerve injury is better than the common peroneal nerve. Radial nerve, it comes in upper limb, common peroneal nerve, it comes in lower limb. But do remember that it is the radial nerve, right? It is the radial nerve. You are taking on the radial side. So you know this is the radial side, right? That's the radial side. That radial nerve, as it crosses the shaft, right? When will in the upper limb, we'll see this thing. And in this topic, though, will come very fast. So as it crosses the shaft, there will be radial groove also, right? So this is the bone, and then there is like a radial groove, and in that groove the radial nerve will be going. So in case if anything happens to this bone, if bone is broken, radial nerve is also damaged, right? That's how that in fracture it occurs. Okay, apart from accident or any of the stab, etc., but this is very common. So that is upper limb radial nerve, and common peroneal nerve, that is in lower limb, right? It has got the worst prognosis. So do remember these two names, right? They can be asked in exam. Okay. So this is the Seddon's classification of nerve injury. Now we're going a bit more scientific. In this, there are several grades of nerve injury. This is normal, right? The first one is normal, and this one is first grade, second degree, and the third degree, or the grade of injury. Here names are important, right? The names are important. We'll just see the names first, and then we'll be going into the detail of it. This is neuropraxia, where there is conduction block, right? Why there has to be only a conduction block? Actually, look at it. The axon is not damaged, right? The axon is there all the way. It is there. So sometimes in our electricity, right, our wires are there, their outer plastic, right, that is damaged, but the inner core wire is okay. So conduction is fine, but you will always call that this wire is damaged, है ना? So that wire is damaged, so that's why this is called as the first degree neuropraxia. So it means there would be some problem in the sensations. Well, we'll see, but just keep in mind. Now here is the axon itself is divided. Axon is broken. The wire is broken. So that is axonotomesis, right? the wire is broken. But still, the connective tissue which is out, right, that is there. This connective tissue can provide the path for the regeneration. But when that connective tissue itself is broken, it is like the whole nerve is literally split open, right? That is what is called as the neurotmasses. It is not only the axonotmasses, it is the neurotmasses. The whole nerve is divided. When the whole nerve is literally cut, right, as if someone is cut with scalpel or scissor, so in that case, obviously, this would be having worst prognosis. And if the axon is intact, the rest of the things, they can be generated. It has got a good prognosis. Let's go into a bit more detail. The first degree, right? First degree, which was neurapraxia, conduction block. This is classically seen in nerve compression injury, right? In nerve compression injury. Axon is intact, right? Myelin, there is local injury. Conduction is blocked. Conduction is blocked because myelin is playing a very major role in the conduction. So if the local injury, if there is some myelin injury, yeah, no problem, that myelin would be, say, regenerating itself, and there is very good chance of prognosis. Nerve conduction studies, normal signal distal to the lesion and abnormal across it. And electromyography, it is normal or some conduction problems, right? Usually this is from a compression injury. Again, there are subdivisions also, that sometimes it is very transient. Say, you must have seen that at times if you just sleep with your bent head, right, on the pressure, and then when suddenly you feel that there are sensations into that entire hand, right, as if it has become numb. Second degree, this is the crush injury, definite injury, right? So that's what is axonotmesis. In this, axon is cut, but Schwann cells, right, they are intact, and then there is no conduction, obviously. So here the nerve conduction studies, that is first 4-5 days, so it is like neurapraxia, and then slowly and gradually it starts giving the Wassermann, this Wasserian degeneration. That is, it will start showing up so many other complications, right? EMG, it is electromyograph, definitely it shows abnormality. And then the third one, that is the third degree, that is where the nerve is in transaction injury. Transaction means absolutely cut, right? So axon is cut, Schwann cells are cut, right? There is connective tissue also that is cut, conduction that is also not present. This is neurotmasses, and initially for few days it will look like axonotmasses, but slowly and gradually it will start degenerating, and then there is no recovery, right? Completely abnormal EMG. This takes us to this final topic, nerve action potential. Yeah, we have already talked about it, right? But this is like high speed. Within minutes, we'll be revising the entire nerve action potential with all the major points. So it would be a sort of a good revision. And thus it will give me a chance to ask you something from this in tomorrow's exam, right? So we start with what's called as the resting membrane potential. We know that that's the cell membrane, and then there was a pump, right? There was a pump, sodium, potassium, ATPase pump. This pump, which is working constantly day and night, right? And outside it is sodium everywhere, right? Inside there is potassium, right? And it is there. But then against this gradient, ATP is used. ATP is the currency of the human body. It picks up 3 sodium, not 1, not 2, but 3 sodium, and it will throw them out, and it will say, okay, come on, 2 potassiums on the return flight, come with me. So 2 potassiums, they come inside, and all these things, they are going against the concentration gradient, right? It is working, and slowly and gradually it is mounting, right? But the point is, these are the pumps which are working constantly day and night, non-stop. Then comes the stimulus. for some reason, right? Either the sodium channels they can open or the potassium channels they can open, and we studied this entire point. So in sodium channel, these are the channels which open. So they say that we don't care whether you want to go out or you want to come in, right? Gates are open. So those gates open, and now sodium, large amount of sodium which was over there, right? They'll say, "Kal chalo chalo, let's rush inside." But then when over here they'll start moving, at one point it happens like everything is balanced. The amount of sodium which is getting transferred from these channels and the amount of sodium which is getting pushed out from the sodium potassium ATPase pump, everything is balanced in such a way that this electrically, right, electrically it comes to a stable voltage, right? A stable voltage. This does not mean that now nothing is happening. Means your needle is stuck at one point, but it is not. It is like the amount of ions which are going out and the amount of ions which are coming in, they both are so equal, right? And that's what is called as the stable equilibrium potential, right? Now gradually all these systems they work, and resting membrane potential, that's where they are waiting for the stimulus to fire, right? So in case of neurons, it is minus 70 millivolt, skeletal muscle minus 90, cardiac muscles minus 90. Only in cases of this pacemaker, right? Because pacemakers, they have got their own system, right? They are like automatic tissues. They are automatic tissues, because they will be handling C nucleotide gates. So restless membrane potential, because it is oscillating, not very stable, and unique feature of pacemaker, fluctuates between minus 60 to minus 40. It is present in, yes, heart, that is SA node, we know about it. It is also present in GIT, right? Interstitial cells of Cajal. So that's where, and this is like part of that enteric system, right? Because they have got also their pacemakers. In case of respiratory system, so we don't have to tell our lungs, right, or our respiratory muscles that yes, breathe in, breathe out. Well, we can take over it, but as such, it's an automated process. You don't have to really say tell your respiratory muscles. That's say thanks to pre-Bodzinger complex in medulla, right? So every time you breathe, say thank you pre-Bodzinger, right? You do it for 10 breaths, you will always remember, right? Pre-Bodzinger, right? And that's in medulla. It is in medulla. So very important. In medulla, we talked about one concept, that in case if poor heart, anything goes wrong to this heart, right, it leads to hypoxia, and this poor fellow is the first one to take that entire attack, right? Because of the lack of oxygen, it is the medulla which is badly affected, and when the medulla is affected, it will lead to problem in the respiration, and we lose someone. This is equilibrium potential, no effective ion movement. So this is as per the ion, right? That's the difference between, say, equilibrium potential and the resting membrane potential. For every ion, there is one specific voltage in which there is no movement for that ion, right? Say for example, sodium. So at 60 millivolt, right, the amount of sodium which is going in and which is coming out, that becomes same. Similarly for this chlorine, it is minus 70 millivolt. Now minus 70 millivolt is as such the resting membrane potential of neuron, right? Because when we say resting membrane potential, it is summation collection of everything, the final output. Then similarly, it is like equilibrium potential of potassium, which is at minus 90. That's for skeletal muscle and say cardiac muscles. So we can also say equilibrium potential as isoelectric potential. Isoelectric, right? There is no electricity. It is a baseline which we are getting, same, right? And the name which we have to remember is called as the Nernst potential. Nernst potential. And then there is an equation for it, Nernst equation. This equation is for single ion only because Nernst was meant for single ion. That's the equation. It's okay, right? Just see it, right? Don't worry much about it, right? Plus or minus 61 log of outside concentration upon inside concentration. At a later stage, we'll take one example, we'll actually calculate, and I'll show you it is not that as complex as it really looks like. And that's the Goldman's equation for multiple ions. This is the figure, right? That's the figure which should be very clearly into our mind. So that's the resting membrane potential minus 90 millivolt, and then the stimulus comes, right? You give the stimulus, it is not so that immediately it will start working. There would be a short phase, right, before it really triggers, and that's what is called as the latent period. Latent period, right? This one. And then that potential difference, it reaches minus 70. This minus 70 is what it is, your threshold potential, because at this point, at this threshold potential, these voltage gated sodium channels in large amount they open, right? Because previously they were opening one after the other, but then as soon as this voltage is there, it's like that surge, right? In cricket stadium or in football stadiums, you must have seen that waves going on, right? When people stand up and then they sit, but this do it in such a good synchronization that the entire stadium as if a wave is going on. Same thing happens over here. These voltage operated sodium channels, they fire. This is what is called as the depolarization. That's our cell. Now large amount of sodiums, they are entering into the system. When they are entering into the system, obviously the voltage which was minus, now it will start rising and it will become plus. At specific voltage, that is at the peak voltage, these sodiums, right, these sodium channels, they will get closed. And now it is the time of potassium, because at this voltage potassiums operate. So potassium channels will open and they'll say, okay, sodium, if you are not going out, right, I have to go in because I'll open my channels. So potassium, which is over here, they'll say, okay, for the sake of, or for the benefit of this cell, of this system, let's go out and try to balance, right? So they'll start going out. And then as they go out, this is what is called as the repolarization, and positive ions, they are going out, and this is a slow channel, right? Potassium. So it is not understanding when to stop. So it will keep on going out, so that here it will say, okay, stop, but still it is going. It takes time, right? So that's what is called as the hyperpolarization, right? Over enthusiasm, right? It goes down. But then once again, it is this also, this chloride channels, they are also there. So it is the chloride which is entering. So that also leads to this negative ion. But then again, all those ion pumps and our sodium potassium pump, they start working, and then they take the whole system back to baseline and ready for the next operation, right? That's what is action potential. This is GABA, gamma aminobutyric acid, right? This is inhibitory neurotransmitter. Just remember the name. Just remember the name. GABA is inhibitory, right? Just wanted a small piece of pharmacology concept, right? Just a small piece. GABA agonist, right? We know agonist means supporter, right? Antagonist is reverse. So it means if this is GABA is inhibitory neurotransmitter. So when this GABA comes into picture, it will say that, okay, no action potential, stop. So if we inject, if we give any of the medicine which is similar to GABA, that is supporting GABA, so they can be used as sedatives and hypnotists, right? Sedatives and hypnotics, because it will really decrease the excitatory component. So that's why barbiturates and benzodiazepines, these are the drugs. They can be used as sedatives and hypnotics. Well, what is the difference, actually difference between sedative and hypnotic, right? Sedatives, they calm the recipient and they decrease the activity, right? They slow down the entire system. While hypnotics, they actually produce drowsiness, right? And they induce sleep. So the concept is that depolarization in neurons, right? The depolarization in neurons, it is because of sodium. Well, that's fine. But in cases of smooth muscles, right? Just remember this. In cases of smooth muscles and SA node, it is because of calcium, right? So that's why whenever we say that calcium channel blocker, that means we are talking about that it is this SA node. SA node would be affected, right? Because SA node, you know that it is a pacemaker. If SA node cannot fire, right? If SA node cannot fire, it will lead to problem of the entire system. So that's the reason. And if it is firing extraordinarily at a higher pace, so in that case also we need to decrease it. So depending upon the condition, we'll be using it. But do remember this part. It is the depolarization in neurons. It is the sodium, and it is in case of smooth muscles and SA node, it is the calcium, right? So I think this much is for today, right? And tomorrow we meet in the morning at 10 o'clock. Yes. Thank you so much. And you have been an excellent audience, very disciplined. Thank you so much. And we meet tomorrow, same time, 10 o'clock. Thank you and bye-bye.